Ladies and gentlemen, thank you for your introduction. It's my honor to update you the chair decision making in end-stage kidney disease patient in Thailand. Okay, this is my disclosure. Uh, the you know that the the treatment of chronic kidney disease and end-stage kidney disease is very expensive, and that would cause a catastrophe to not only the patient and family household, but also for the government. This is the last International Society and Global Kidney Health Atlas in 2023 that include 167 countries. Uh, the prevalence, the global prevalence of CKD is about 9.5%. That would in about 850 million people had CKD, and about 0.1% had kidney failure. So Asian countries have highest prevalence of treated kidney failure. You can see in this picture that Thailand, Japan, Taiwan, Korea, Singapore, Malaysia has the highest among highest prevalence of treated kidney failure, including hemodialysis, peritonitis, and kidney transplantation. This slide shows the international comparison of the prevalence of treated end-stage kidney disease by dialysis per million population reported in USRDS. This highlights that Asian countries are among the top 5 with the highest prevalence. It's Taiwan, Japan, Korea, Singapore. And uh, Thailand ranked number 13 after Malaysia and Hong Kong. This may reflect the total number of end-stage kidney disease were highest in Asian countries or the government policy for the KRT reimbursement in these countries. The Kingdom of Thailand, the population about 66 million population, the GDP per capita is about 6,394 US dollars. That ranks among 91. We have 3 different national public health insurance scheme. The civil servant medical benefits scheme will serve about 7%. This program provide coverage for the government employees and their dependents and retirees. The Social Security scheme cover private sector employee, about 16% of the population. But the Universal Coverage Scheme under the National Health Security Office cover the rest of the population, that about 75% or about 45 million people. From Thai Seek project, we have that survey the preference of CKD in Thai population. We have the preference of all state about 17%. That about 10 million, almost 10 million of, of adult population had CKD, and patient with stage 4 and 5 non-dialysis about 1 million. The treated end-stage kidney disease is about 150,000 patients in the last few years. This slide shows the development of the reimbursement scheme and also the prevalence of kidney replacement therapy in Thailand. And in 1960, PD was taking first step as a KRT, closely followed by hemolysis in 1962. That would save. Oh, sorry, I skipped the patient. This also this save save the patient life with patient with acute kidney injury. For treatment of end-stage kidney disease, chronic hemorrhages started in 1964, kidney transplantation in 1972, and CAPD in 1982. At that time, no any national reimbursement scheme for KRT for end-stage kidney disease patient. In 1982, the Ministry of Finance provided support of hemodialysis among patients covered by civil servant medical benefit scheme, which cover about 5 million population. In 2003, Social Security Office expand coverage to include hemodialysis, which cover about 15 million population. 5 years later, the National Health Security Office announced the PD first policy uh, and KT to support the rest of the population under Universal Coverage Scheme. Under Universal Coverage Scheme, patients who are suitable for PD can decline PD and choose hemodialysis as first treatment, but they have to fully self-fund for dialysis-related costs. On the other hand, patients who are not suitable for PD because of a PD contraindication or history of PD technique failure are able to access hemodialysis without additional payment. So, as you can see that after the PD first policy, the total number of patients on kidney replacement therapy gradually increasing, not only the PD patient but also the hemodialysis patient. The number of you can see the number of PD in the blue line progressively increased until the change of policy in 2002. And 2002, the government announced the patient-centered care approach that we call free choice dialysis. So the patient under UC will get support whether they choose PD or hemodialysis. This is when the patient-centered care or free choice policy. And what the difference from PD first policy, that the PD first policy was because announced in 2008 that to maximize population coverage and to help the catastrophic health expenditure for the patient and family, and also the capitalize the superior cost effectiveness of PD over hemodialysis, enhance accessibility to home-based dialysis, and align with health system capacity by managing infrastructure demands, and minimal indirect costs for patients, minimize costs and domestic PD industrial investment, and spare hemodialysis for those who are essentially needed. There are about 5,000 to 6,000 patients with self-pay for hemodialysis at that time. And in 2022, the NSHO announced the patient-centered care policy to improve patient choice and financial protection for patients who had self-pay for hemodialysis. But the policy transition in 2022 is the result of a policy window mainly caused by the political driving force and problem caused by some limitation of the 2008 PD first policy and the support of the significant stream of universal health coverage policy to prevent the catastrophic health expenditure. After the changing of the policy, there's the vastly increased the number of total case of patient with kidney replacement therapy, mainly on hemodialysis. You can see that in this after changing the policy, the number progressively increased and mostly in hemodialysis, and the number of patients on PD decreasing. But the problem after changing the policy, before changing the policy, you can see that the set budget and the actual budgets are mostly matched. But after the changing the policy, you can see that this number in 10 in million baht. So you can see that the set budget is about after and in the year 2022 about 10,000 million baht. but the actual budget increased about 2,000 billion baht. And then after that, you can see the imbalance of the actual and the set budget. Not only the problem of the budget, but also the other consequence after changing policy because the limited number of the vascular surgeon to perform the permanent vascular access. You can see that after changing the policy, the number of the non-tunnel central venous catheters vastly increased. The time to permanent vascular access was prolonged. You can see that there are also many patients were on the urgent start of hemodialysis. And worst is the survival. Before changing the policy, you can see that the mortality rate of patient on hemodialysis was just a little bit lower than patient on peritoneal dialysis. But after changing the policy, the increasing number of the total case of hemodialysis also lead to uh, the number increasing the case of hemodialysis death. Compared with the PD, the mortality rate declined. And we analyzed the early mortality by look at the number of deaths within 90 days after initiation of hemodialysis is significantly increased up to 30% of the new patients die within 90 days after changing the policy. But the number of the PD deaths is decreasing. And we look at the survival, the conditions of the patient who had night early mortality. You can see that the urgent start of PD and older age, also with the higher comorbid by Charlson Comorbidity Index. So the excess early mortality in hemodialysis patient may be from the increasing demand, the patient recruit into the KRT program were not suitable for hemodialysis. And this also includes the patient with cardiovascular disease and other comorbid conditions. Also, maybe from the inadequate hemolysis service supply, nephrologists, hemolysis nurses, vascular surgeons, and also some issue on the understandard of hemolysis care because of the expansion of the hemodialysis units. So 2 years after the policy change, the NSHO in collaboration with the Health Intervention and Technology Assessment Program or HITAP and Ministry of Public Health, the Nephrology Society of Thailand and the International Society of Thailand made the consultation meeting on the lesson learned for Thailand dialysis policy during January 29 and 31st in Ayutthaya. The committee include the expert in Thailand and also from international perspective. For example, Professor Vivekananda from India, also the past president of the ISN. Also, international committee from Hong Kong, from Canada, and from other countries. We had an intensive meeting and this with thorough discussion, and we summarize after the program that the positive impact of the changing policy is a reduced financial risk for patients with any KRT option and more flexibility in choosing the appropriate dialysis modality, and also the increased hemolysis service units throughout country. But the negative impact is there are indications that some patients who may not require dialysis were prescribed to dialysis. Also, maybe patients are not suitable for KRT, either hemodialysis or PD were included into the program. So that will cause a very high mortality. Also, the increased waiting time to obtain permanent vascular access that maybe contribute some mortality because of the increased rate of the infection. The one other consequence include decreased PD usage, imbalance of healthcare personnel to meet the PD demand, and subsequently financial burden and create opportunity to cost for health system. So after this meeting, the decision of the Executive Board, National Health Security Office, on November 4th, 2024, they increased they decide to increase the proportion of new patients receiving PD and control the budget for CKD service not to exceed 12%. This at this time about 9 to 10% of the total NHSO budget, and the reduced incidence of dialysis case to delay or prevent the progression, and ensure our patients with kidney failure who choose dialysis receive information about the option for reversible kidney transplantation. That would lead, and the National Health Security Office announced the PD first policy, the new PD first policy starting the last April. And so the reimbursement include the PD, either CAPD or automated PD, kidney transplantation, and including conservative kidney care. And hemodialysis only can get reimbursement only patient with contraindication, either medical or social contraindication for PD or APD. So this would lead to the shared decision making for advanced CKD or end-stage kidney disease patients. Shared decision making is a key component of patient-centered healthcare, and it is a process in which clinician and patient work together to make decisions and select tests, in this case, for the option for kidney replacement therapy or conservative kidney care that balance risk and expected outcome for patients with preference and values. Patients with CKD are required to make a difficult decision, negotiate between the risk of the disease and risk burden of disease, and also the risk of the procedure and the benefit of proposed cost. And this is extremely challenging because it's that would impact survival and quality of life of the patient. And however, there are several studies show that shared decision making can improve patient preparedness. For example, decrease the number of patients with unplanned dialysis. Yes. And motivation, satisfaction, and adherence to treatment or decision agreed upon. Also, some studies show that the patient that had proper decision making had a lower mortality. So I'm not gonna lecture on the process of decision making, but that the major this is one of the popular model for this decision making for advanced CKD and ESKD. That will be included team talk for the patient education discussion on the option available, and also the option talk, and finally for the decision talk. That would take some time. Many studies show that would take about at least 5 to 6 months from the beginning of the team talk to the option talk. For the model of the management of end-stage kidney disease under universal coverage, the nephrologists have to discuss the patient who are at risk of end-stage kidney disease. If patient are not suitable or unwilling for kidney replacement therapy, then will go to conservative or palliative care or withdrawal of dialysis. Patients who are suitable for KRT, we have to assess for the transplantation. If they are eligible for transplantation, we assess for the living donor transplantation and proceed to preemptive transplant. Otherwise, they will go to the waiting list for deceased donor transplant. The patient who are not unsuitable, who are unsuitable or unwilling for transplantation, we will assess for the contraindication for peritoneal dialysis. If no contraindication, you go to peritoneal dialysis. If they have contraindication, either medical or social, they will go to hemodialysis. Patients who are listed for disease donor transplantation have to go to the same process, either PD or hemodialysis. The NST, the National, uh, Nephrology Society of Thailand has revised guidelines for for shared decision making on the kidney supportive and palliative care in 2023 that include infographic. The recommendation for shared decision making will include the training of the personnel, the information of the KRT and conservative kidney care, and the consideration before making decision, patient and family engagement, and the final decision after all this process. And in doing so, the Nephrology Society of Thailand make the SDM8. They did do the video clip that the doctors, nephrologists, the doctors that play a role with the patient and also some patients. For example, the PD patient and KT donor also were included in the SDMS. That you can look at the website of the Nephrology Society of Thailand. And also, we are planning on if you are familiar with the My Kidney, My Choice, we are planning to uh, simulate the tool for the patient and also for the nurses or physician to in Thai that you can patient that can make their choice and their preference and also the final decision. We also provide the NST and Thai Transplant Society checklist for eligibility for KT. Every patient had to make the do the checklist. For example, patients are older than 65, high BMI, severe psychiatric disease, or non-adherence, for example. And you have to put into the medical record and also I would say the pre-authorization form. And also, this is form from National Health Security Office for the counseling and transaction making consent form that every patient register for the KRT had to fill the form after they discuss with the doctors and also make the decision which option that they want to suitable for them. Now we in the development of the pre-authorization for kidney program or PAK program for end-stage kidney disease that we are use nationwide, but now it's just in the state of development, and some hospital also in the trial period for some hospital. This include the general demographic, comorbid condition, and functional status, clinical situation and laboratory result, contraindication for PD, initiation for indication for initiation priority, and final decision. This program will include the comorbid condition and the Child's Comorbidity Index and fail score. So if you fill out this, for example, coronary artery disease, heart failure, stroke, and if they fill out this, uh, we can calculate the comorbidity index. Also, how the functional status of the patient and also the performance status. Also, this include the previous history of hospital admission that we will get from the reimbursement, and also include the supply question for conservative care. Also, in this PAK program will have the indication for initiation for dialysis. For example, estimate GFR less or equal or less than 6 ml and per minute, and also even after complication. And there will be summarized for the nephrologist perspective. Is the patient suitable for transplantation, APD, CAPD, or hemodialysis? And the final decision after transaction making So this final slide, session making for advanced CKD and SKD, end-stage kidney disease in Thailand. We are still in the phase of development. We require optimal training for staff for the unbiased uh, information and also the comply with the policy, national policy, and require the monitoring. And I would, okay, that. Thank you for your attention.
Well, thank you very much, Dr. Vuddhidej, for your wonderful presentation, especially highlighting the policies in Thailand. So I'd like to request you to provide a brief summary in Thai language to our Thai participants here. Just an overview of the key points of your lecture in Thai, please.
ครับก็สรุปว่าเรื่องของ Session Making เนี่ยนะครับมันเป็น process ที่ควรจะต้องทำกันอยู่แล้วนะครับแต่ว่าที่ผ่านมาเนี่ยเรื่องของ tool หรือเครื่องมือที่ใช้เนี่ยยังอาจจะไม่มีความแพร่หลายทางสมาคมโรคไตเนี่ยก็ได้จัดทำเรื่องของ tool ขึ้นมาก็คือเป็นวิดีโอซึ่งสามารถจะนำไปใช้ได้เลยจริงๆก็ได้แจ้งทาง Service Plan ของกระทรวงสาธารณสุขสามารถจะเข้าไปใช้ได้นะครับแล้วตอนนี้เนี่ยเราก็คงจะสามารถที่จะเข้าไปดูข้อมูลอื่นเพิ่มเติมนะครับของในเรื่องของการประเมินผู้ป่วยซึ่งมันมีอยู่ในไกด์ไลน์อยู่แล้วคนไข้ที่อายุเกิน75ปีขึ้นไปนะครับก็สามารถจะเข้าไปดูในไกด์ไลน์ของ Conservative Palliative Care ได้เพราะฉะนั้นโดยสรุปก็คือว่าทางสมาคมพยายามจะหาเครื่องมือต่างๆเนี่ยที่ช่วยให้กับทีมแพทย์กับพยาบาลที่อยู่หน้างานนะครับในการที่จะให้ความรู้ผู้ป่วยตั้งแต่เป็นlate stage ของ CKD เช่น GFR เป็นสเตจ4หรือต่ำกว่า20นะครับให้ความรู้แล้วก็ในอนาคตในการที่เราจะเกิดมีการลงทะเบียนผู้ป่วยตั้งแต่ CKD GFR ต่ำกว่า15คือเข้าสเตจ5ตั้งแต่ early ก่อนที่จะไป start เรื่องของ KRT นะครับขอบคุณครับ
Thank you very much, Dr. Vuddhidej. So currently there is not yet any questions from the audience, and since we're just right on time, I'd like the audience to give another round of applause to Dr. Vuddhidej for his wonderful presentation.
ขอบคุณครับ